Hello everyone, we are from SGD B3 and now we are going to present to you all about our student project with the title of Clinical Diagnosis of Syncope. The introduction of each member of the group will be conducted later. I will go first. Dear doctors and friends, my name is Natalia with the 3 last digit student number 109 and now I am going to present the whole first chapter of this student project. First, the background. Syncope or fainting is a transient loss of consciousness which has 3 characteristics. First, sudden onset, second, short duration, and the third, spontaneous recovery. Syncope has a lot of underlying diseases from benign conditions such as dehydration to a warning sign of life-threatening illness. Even with expert consultation and diagnostic testing, the cause will still remain unknown as it only covers for 10 until 40% of all cases. In conclusion, the process of making clinical diagnosis of syncope is complex and important. Clinicians really need to rely on a multifaceted approach that combines patient history, physical examination, or additional test reports in order to establish a proper diagnosis. In this literature review, we are going to gather and review various clinical information regarding to syncope from various sources. Second, the problem formulation is written on the slides. And the third one is the objective, that is to answer all of the problem formulation that is written on the slide. And the last one is the benefits. We aim to improve student knowledge regarding multi-aspect of syncope, to increase one's understanding of the definition, clinical manifestation, and many more aspects of syncope. That's all from me, thank you.
My name is Gede and Renathan with last student number 193, and now I will explain about the definition of syncope. Syncope is a transient loss of consciousness and postural tone followed by spontaneous recovery. It is a symptom of an underlying disease process rather than a disease itself. Syncope ultimately results from a decreased cerebral perfusion. Syncopal episode may occur suddenly and without preceding sign or symptoms, or may be preceded by dizziness, lightheadedness, diaparesis, nausea, visual disturbance, or other signs and symptoms. The 2018 ESG guideline for the diagnosis and management of syncope defines syncope as transient loss of consciousness due to cerebral hyperfusion, characterized by a rapid onset, short duration, and spontaneous complete recovery. The next part will be explained by my colleagues.
Hello everyone, my name is Dewa Gede Agung Guptha, with the last 3 digits of name is 072. So at the present moment, I'll be explaining you about epidemiology of syncope. In all age categories, syncope is very prevalent, occurring in 23% of patients over the age of 70 and 15% of patients under the age of 18. Age-related increases in syncope incidence and prevalence are observed, with a 30% recurrence rate. Pure syncope patients made up 1.1% of all emergency room visits, according to a study conducted in Ireland. Over 75 years old is 21%, and between 45 and 54 years old is 20% of Americans experience syncope, with men outnumbering women by 15% to 22%. That's all from me. Thank you for your time.
Okay, thank you for the opportunity. My name is Wilbert Purnamasidi with last 3 digit of my student number is 135. And now I will continue the presentation and I will explain about etiology of syncope. So, etiology of syncope. There are many of etiology of syncope such as neurocardiogenic, cardiac syncope, neurological disorders, orthostatic hypotension, carotid sinus hypersensitivity, and other causes or other etiologies such as endocrine and psychiatry, etc. Maybe that's all from me. I give it to my friend. Thank you.
Allow me to introduce myself. My name is Carla Noveline Manullang with my last 3 digits are 146, and now I'm going to present about pathophysiology of syncope. Based on their pathophysiological origins, the main causes of syncope can be summarized into reflex syncope, cardiac syncope, neurological causes, and other causes. The mechanism of vasovagal syncope is triggered due to decreased venous return, resulting in inadequate ventricular filling and a vigorous cardiac contraction. Cardiac syncope results from inadequate effective cardiac output and may reflect serious underlying structural heart disease. Neurological causes are cerebrovascular disease, autonomic dysfunction, and subclavian Still syndrome. Focal neurological deficit in stroke, vertebrobasilar transient ischemic stroke, migraine may be presented as syncope. Other causes of syncope, such as endocrinological causes that can be presented as orthostatic hypotension to cause autonomic dysfunction or hypovolemia. That's all from me. The next part will be presented by my colleague. Thank you.
My name is Aisyah Taqiyyaa with 3 last digit number is 076. Diagnosis of syncope. Evaluation to diagnosis syncope. Electrocardiogram. A test records the electrical activity of your heart. Stress test. There are many types of stress tests that involve you exercising or using drugs to put stress on your heart. Sometimes, some types of stress tests will also look at ECG changes or perform an ultrasound of your heart. A stress test can also be performed using nuclear imaging. Ambulance monitor. A monitor viewer uses electrodes to record information about your heart rate and rhythm. Fourth, echocardiography. A test that uses sound waves to create images of structures in your heart. The ECG or electrocardiogram is the most useful diagnostic study, yielding an etiology of syncope in approximately 5% of patients.
Thank you for the opportunity. My name is Adrianus with the last 3 digits of my study ID number 104, and I'm going to explain about the differential diagnosis of syncope. Okay, so the first one is orthostatic hypotension. It's a condition in which blood vessel is unable to regulate blood pressure upon standing, which causes dizziness and lightheadedness. But unlike syncope, it doesn't cause unconsciousness. Next, we have seizure. It is similar in terms of altered consciousness, resembling syncope. But seizure can be distinguished from syncope as it has jerky movements. And for the third one, it's metabolic disorders. It is less common but similar symptoms to syncope. Hypoglycemia, for instance, causes dizziness and loss of consciousness, and electrolyte imbalance can cause fainting. And the last one, in general, is angina. It is characterized by chest pain due to abnormal blood flow. Both angina and syncope have similarities in terms of arrhythmia and involves chest discomfort. Moreover, angina may cause dizziness.
My name is Ningrum and I will explain about the other differential diagnosis. The other differential diagnoses are very broad, but in elderly patients, there are several common differential diagnoses such as bradyarrhythmia and carotid hypersensitivity syndrome or CSS. Bradyarrhythmia indicate the presence of several rhythm disturbances including sinus node dysfunction or SND and atrioventricular block or AVB. It also has signs of focal neurological deficit, which often refers to syncope. Routine electrocardiography or ECG examination can differentiate it from syncope. The other one is carotid sinus syndrome or CSS. CSS is associated as a result of hypersensitivity of carotid sinus receptor to accidental pressure. CSS occurs in the autonomic nervous system with the main symptom related to syncope.
Thank you for the opportunity. My name is Gede Saputra with last 3 digit number of name 0 and 18, and I would like to discuss with you guys about the treatment and management of syncope. As we have discussed before, there are 4 types of syncope: vasovagal syncope, cardiac syncope, orthostatic syncope, and neurogenic syncope. For vasovagal syncope, the non-pharmacological treatment can be lifestyle modification and counterpressure maneuvers. And then for the pharmacological treatments, there are 2 options: beta blockers such as propranolol, timolol, and SSRIs such as fluoxetine. And then for cardiac syncope, we are gonna focusing on arrhythmia management by using pacemakers, beta blockers, amiodarone, and even surgical treatment. And then for orthostatic syncope, the non-pharmacological treatment can be fluid and salt intake management using compression stocking and doing the head of bed elevation. For pharmacological treatment, we can take fludrocortisone, midodrine, and pyridostigmine. And then for the last one, for neurogenic syncope, we are gonna focusing on treating the underlying neurological disease.
Hello, my name is Margaretha Jesslyn with my last sheet number is 248, and now I will explain further on the treatment of syncope. So, to further enhance the explanation before, these are few additional information that are worth considering. So, the first one is implantable device. For certain types of syncope, particularly those who is caused by specific arrhythmias, implantable device like ICTs or CRT or implantable device like implantable cardioverter defibrillator or cardiac resynchronization therapy device may be recommended to regulate heart rhythm and prevent recurrent syncope. And then we have psychogenic factors, addressing any anxiety, stress, or emotional factors contributing to the syncope episodic. And then we have advanced cardiac evaluation to understand the mechanism of syncope and guide treatment decision making. And then shared decision making, taking into account an individual preference and values. And the last one is educational and support group to provide information and emotional support related to syncope management and coping strategies. Thank you.
My name is Nandhita Naaz with the last digit of student number 189, and now I will explain about the prevention of syncope. To prevent syncope, people who have risk factors for syncope or have had syncope before are advised to take preventive measures such as recognize situations that can trigger fainting and avoid them, learn to manage stress by practicing breathing techniques or doing yoga, and keep the body fit by getting enough sleep and rest, drinking enough water, lie down and raise the legs slightly higher than the head if feeling the symptoms before fainting. And the last one is regular checkups at the doctor if there are health problems such as diabetes or heart disease.
Hello, my name is Carla, and my last digit number is 016, and I will explain the prognosis of syncope. So the outlook for syncope is depend upon its underlying cause. So numerous studies that have compared mortality rates between cardiac and non-cardiac syncope suggest that the risk of death is elevated for all syncope patients, particularly those with cardiac origins. And syncope related to neurological factors is also linked to an increased risk of stroke. Another study affirmed that individuals who experienced recurrent syncope faced an elevated risk of death within 1 year. Furthermore, syncope patients who had not been previously hospitalized also exhibit an increased risk of adverse outcomes, including death, stroke, cardiovascular, hospitalization, device implantation, and recurrent syncope. So in summary, the prognosis of syncope is largely dictated by its underlying cause, particularly the presence and the severity of heart disease. So that's all from me. Thank you.
Hello, my name is Kevin Andrian Candra with my class year number 095. Today I will explain chapter 3, conclusion. Syncope. Syncope is a temporary loss of consciousness and body posture followed by spontaneous recovery. Syncope often caused by factors such as vasovagal reflex, pulmonodepletion, or treatment-related problems. Accurate diagnosis and treatment depend on identifying the underlying causes. Diagnosing syncope involves tests such as an electrocardiogram, stress test, echocardiography, tilt-table testing, and assessment of autonomic nervous system function. Preventing syncope involves recognizing triggers and avoiding them, managing stress and panic, maintaining physical fitness through sleep and rest, and staying hydrated. That's all from SGD B3. Thanks for your attention. Thank you.